Good morning, everyone. Presenting a case of 47-year-old lady hailing from West Bengal. She's a housemaker. She presented with complaints of dyspnea on exertion since 1 year and palpitation since 6 months. History of presenting illness. She presented with complaints of dyspnea on exertion since 1 year, which is progressive in nature. She's currently in class now, NYHA 3 with no reliving factors. She also complains of palpitation since 6 months and gives a history of one episode of syncope 6 months back, which lasted for few minutes, with accompanied with right upper limb weakness, or with also impaired right side vision. Um, there is no complaint of orthopnea or proximal nocturnal dyspnea. No history of chest pain. No history of cough or any hemoptysis. No history of pedal edema. No history of fever or joint pain. Coming to her past illness history of similar complaints for last 5 years. She's on medication, diuretics, furosemide with spironolactone. No history of hypertension, diabetes mellitus, bronchial asthma, or any renal disease. No history of any hospitalization. Family history, nothing significant. Personal history, her diet is mixed and is reduced. Sleep is adequate. Bowel and bladder normal. Menstrual history is regular with 4 by 28 28 days cycle. With her obstetric history, three living children were two male and one female. All were vaginal normal delivery, and the pregnancies were uneventful. Uh, gen-
Hold on. In your history, you said there was a history of syncope followed by
yes.
neurological deficit. Is the neurological deficit persistent or is it improved?
Since then, yes, sir, it's the same. Right upper limb weakness is there.
And vision?
Vision is also like right side temporal hemianopia is there since then.
Yeah.
That
Okay.
is when she came to Narayanas.
Obviously, it is not a syncope. It must be an embolic episode.
Embolic, yes, sir. But presented with syncope, TI. Sorry, sir.
Uh, it's not a presentation of syncope. This is actually an embolic episode, and first they become unconscious. That's part of it. Then later on, when they wake up, they realize they got a weakness of that. That's actually an embolic episode. The
Yes.
palpitation before that,
No, sir, not there. 6 months she had it, and after that, a month later, she had this episode.
actually, it's an atrial fibrillation and it's an embolic episode.
Yes.
Didn't say anything about the paroxysmal nocturnal dyspnea.
No, sir. Last 5 years, I asked her. She just had exertional dyspnea, and then she had consulted, and she was on medication, and she was diagnosed of this disease since 5 years, and was on consultation with the physician. And once progressed symptoms and with palpitation, then presented here. Coming to general physical examination, she is well oriented to time, place, and person. Poorly nourished and with moderate build. Her height is 153 centimeters, weight 35 kg, BMI 14.9, which is bit lower. Her vitals, heart rate 82 beats, which is irregular, and blood pressure 128 by 68 millimeters of mercury, measured in the left upper limb as well as in the left lower limb. It's the same. Respiratory rate is 16 cycles. She's febrile. JVP is not raised. Pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema were all noted to be absent. Cardiovascular examination on inspection, chest appears symmetrical, no scars. There's an apical impulse seen in the left inframammary region, just lateral to the mid-clavicular line. On palpation, the above findings were confirmed and the apical beat present in sixth intercostal space, just lateral to mid-clavicular line. It is tapping in nature. Also, there was a palpable S2 in the left parasternal region, more in the upper parasternal region. On auscultation, S1 S2 heard. There was a loud S1 heard over apical region, uh, and opening snap heard over apical region with a low pitched diastolic murmur heard over apex, which was best heard in the left lateral position, and it was found to be radiating to axilla. There was a loud S2 heard over the left upper parasternal region. No other murmurs appreciated.
Hold on. Diastolic murmurs don't usually radiate. Definitely not into the axilla. It is usually a systolic murmur which radiates into the axilla. Okay, so you better go back and check on your physical findings.
Okay. Uh,
Or
no other murmurs appreciated, sir. Only diastolic murmur in the apical region was heard, and it was best heard in the left lateral position. And there was a loud S2 heard in the parasternal, left parasternal region. And on central nervous system examination, her higher mental function tests were intact. Right upper limb, the hand, the grip was not adequate. It was power of +4/5. Left upper limb, bilateral lower limb, the power was normal, 5/5. Right temporal region, on just asking her to close the left eye, and she complains of total darkness on the temporal side. Apart from that, the vision test, only this could be assessed. Respiratory system, normal bronchovesicular sounds heard all over the lung fields. Per abdomen, no hepatic pulsation. It was soft, non-tender, no organomegaly. Normal bowel sounds are heard. Uh, Coming to diagnosis on clinical examination and history, 47-year-old female with history of dyspnea on exertion since 6 years, which has progressed to class NYHA class 3, with history of thromboembolic episode with neurological deficit and vision impairment. Um, with clinical examination finding of a low pitch diastolic murmur over the apical region with loud S2, uh, is likely to be an acquired valvular heart disease, severe mitral stenosis with moderate pulmonary hypertension in AF. With probably a rheumatic etiology, not an heart failure, and with no signs of infective endocarditis.
in your this thing, what are the signs of severity in this patient? Why do you say
Severity.
severe MS?
uh, Low pitched diastolic murmur heard, sir, which is evident even in the in the lying down as well as in the lateral position,
That
and
is
a
any,
loud S2,
that
loud S2.
does not say low pitch diastolic murmur per se does not say severity.
The duration was prolonged, sir, and there was a loud S2, and she presented with the class 3 symptoms, and uh, which with no relieving factors even on medication. So class 3 symptoms with diastolic murmur with loud S2.
Anything else? You found one particular sign and that has got some relevance to severity. You heard an opening snap,
Yes, sir.
so
Uh,
the S2 OS interval tells you the severity.
yes.
Of course, it is difficult to
Difficult.
detect it clinically, more likely that it is seen on the phonocardiogram. But if it is more or less very close to the S2, S2OS interval is very close to each other, then it signifies severity.
Yes.
Would you get pre-systolic accentuation?
No, sir. AF is there.
Hmm, good. Okay. So what do you want to do? Does she require any intervention? Does she require any treatment?
Yes, sir. She is symptomatic with the neurological deficit and an AF. She definitely requires treatment. would like to further confirm with the ECG
Will the
to
neurological deficit improve with
no,
this?
sir.
That is
Further
what
embolization can
uh,
be prevented.
to prevent further. Okay, because this will not improve.
Yes.
But she's got severe pulmonary hypertension as per your presentation. You think she's operable?
Yes, sir.
How? In all other cases with severe pulmonary hypertension, you don't operate. Why here?
This is a reactive pulmonary hypertension, which with the correction gradually it comes down with the surgery.
We have discussed this number of times earlier, so you should know the reason. It's an obstructive lesion
Yes,
causing back pressure to the pulmonary circulation. So you have whatever stage of pulmonary hypertension in mitral stenosis, you have to relieve that. So
yes,
that should be your answer. Don't go on beating around the bush something. So these are specific questions that will be asked, and you should know the answers. You please write down these answers and keep
note of
reading these.
yes.
Practice these answers. So what
So,
are you going to
most
do?
important clinical sign for severe mitral stenosis.
The duration is more proportional to the severity, as well as the O2 S2O is interval signifies shorter this interval, severe the MS. Less than
You,
0.04 seconds.
it's usually, you cannot make out with stethoscope whether it is 0.12, 0.1, or 0.08, then it's closer and closer. But the most important sign is a very loud first heart sound. Why I
It,
say that's the most important clinical sign for a severe mitral stenosis. What does a very loud first heart sound signify?
the tensing of the valve after the closure, sudden tensing of the valve once there is to after the closure of the valve, uh, and then
Not correct, not correct. Normally in a heart, normal heart, in diastole, the really diastolic phase, when there's a high flow. In mitral stenosis, because the LA pressure is always higher, when the systole starts, the mitral leaflet is further down. Normally, after the initial high flow in a valve, the valve floats a little bit, and so when the left ventricular systole starts, it closer from a short distance. Whereas in severe mitral stenosis, it always opens further down the valve, especially the anterior leaflet is so far down, and then suddenly systole starts, the excursion it has to go is very high. It's like classically what people describe by closing the door from a, suddenly from a big opening to a small opening closing. That's the difference. So, because during onset of systole, the mitral leaflets are so farther down, sudden systole, the excursion of the, especially the anterior leaflet, is so much it closes with a bang, that's the first start sound. Then opening snap, the just opening snap. Then full length murmur and in sinus rhythm with a prehistoric accentuation. So everybody says MDM, MDM. It's not MDM. So the importance of loud first heart sound you must. Okay.
Coming to uh, investigations, 12 lead ECG. It's a standard 12 lead ECG with a
No,
irregular
it
heart.
is not seen.
Not seen, sir. Now,
ECG not okay. Yeah. Okay.
with a controlled AF with a rate of ventricular rate of 80 beats minute. Uh, um, no other signs are evident of mitral stenosis. The P mitral and all cannot be commented. There's no P waves, and it's a normal axis. There are no tall R waves in V1 or V2 to comment on the pulmonary hypertension or RV hypertrophy. It's AF with a controlled AF with ventricular heart rate of 80 beats per minute. Moving on to chest X-ray. Chest X-ray PA view, well exposed, well centralized. Uh, it's situs solitus levocardia with a CT ratio of 0.6 and LV type of apex. Double atrial shadow seen with straightening of left heart border. Um, Also, there's a prominent aortic knuckle and signs of pulmonary venous hypertension. Peribronchial cuffing is seen most on the right lung field. The costophrenic angles are free, are and splaying of carina is also present, signifying left atrial enlargement.
Why do you think she has got a left ventricular apex?
Mm.
Is that normal in MS?
No, sir. It should be, left ventricular apex with the downward tilt is mostly involvement of aortic valve as well, aortic regurgitation. It most commonly mitral stenosis with involvement of any aortic regurgitation, then prominent aortic knuckle and uh,
Aortic valve may be normal, completely normal, and still have left ventricular apex. What is the reason?
could be systemic hypertension also can be causing a
Simple
long
thing, simple, straightforward thing. The MS could be associated with MR.
with MR. Yes.
So there is a volume overload and then a left ventricular apex.
Yes.
And you also heard one murmur which is heard in the axilla. More likely that you've mistaken that to be a diastolic murmur. It could have been a MR murmur. Hmm. Okay. Is there evidence of pulmonary hypertension on the X-ray? What are the signs of pulmonary hypertension on the X-ray?
Prominent bronchovascular markings are there, sir, but only peribronchial cuffing is seen on the right upper lung field. Uh, Apart from that, curly A lines and B lines are not well defined.
The first thing is a redistribution of
To the
the upper veins, which causes because of pulmonary venous hypertension. That comes first. Then you will have enlargement of the central pulmonary artery, and then you will have end-on views of the pulmonary arteries with bronchial cuffing. So these are the signs and symptoms of, these are the classical signs of pulmonary hypertension on an X-ray. Pulmonary curly lines come when there is gross lymphatic obstruction and the enlargement of the lymphatics causing pulmonary edema. And then last stage, the pulmonary edema will give you a typical bat wings appearance.
hilar shadow. Yes.
So these are the stages of mitral stenosis on the X-ray. Okay. As a surgeon, what do you want to know in your echocardiographic investigation in this patient?
Um,
Now you have decided this requires surgery or
y-
treatment, whether
yes.
it is whether you want to do surgery or a balloon valvotomy, we don't know. So you have to decide what you're going to offer this patient and why. So for that, you need to know certain criteria on the echo. You please enumerate those things and tell me what you want to do in this patient.
Look for the mitral valve area, pliability of the leaflet, subvalvular apparatus, uh, then LV function. Look for other involvement of the valves because uh, multivalvular disease is common with mitral valve in rheumatic heart disease, commonly involving aortic valve.
Tell
If
us.
my uh, This 2D echo of hers reveals severe mitral stenosis with thickened and mildly calcified leaflets with PML mobility restricted, and both commissures are fused. Significant subvalvular fusion is also there, and critical stenosis with mitral valve area of zero point 0.8 and gradients of 17 by 10. Uh, Mean gradients is 10, which is severe. And aortic leaflet, mildly calcified and mild to moderate AR with vena contract of zero point 0.4 and borderline PA pressure and EF of 45 to 50% is mentioned, with a slight enlargement of left atrium. There is no LA clot or LA appendage clot noted on echo.
So anything else you want to know?
Tricuspid valve, if severe, moderate to severe pulmonary hypertension, then there could be functional TR as well.
Is it there?
No, sir. TR is mild in her case.
Okay. Anything else?
What the PA pressure you said?
Um, 39 millimeters of PA systolic pressures and 39 millimeters, which is not significant. So 20, more than 40 systolic, or a mean of at least more than 25. Mean is not mentioned. Systolic pressure is 39.
So your criteria of severe pulmonary hypertension is not there. He's got
Yes,
some amount of my subvalvular fusion with a thickened leaflet.
yes,
Okay.
sir.
So what do you want to do? What do you want to do in this patient? Is there anything else you would like to do before offering surgery or balloon valvotomy?
Since she has a neurological deficit, we would like to do transesophageal echocardiography to confirm LA clot.
Very good. Well,
Very
many a
good.
time the transthoracic echo will miss it, so you have to confirm it with esophageal echo. Very good. Okay, and then
47-year-old can go ahead with CT coronary to know her coronary artery status, which has been done, and there is only mild coronary artery disease. But however, CT has picked up LA appendage clot, and so they did not do in this case any T. And with the CT report itself, she her workup with transthoracic and CT and MRI brain for her stroke was done, which showed chronic lacunar infarcts and a thalamic infarct. Uh,
So
coming to find.
what are you going to offer this lady? Is she fit for balloon valvotomy?
Sir, LA appendage clot, in presence of LA appendage clot, it is a high risk for embolization. So balloon mitral valvotomy is relatively contraindicated.
She also has a neurological deficit previously. It's not a good idea. Okay. So what are you going to do?
Echo also shows moderate aortic regurgitation, and clinically no signs, but X-ray and echo wise, LV is looking volume overloaded. So would like to do intra-op also a T, and to evaluate for aortic valve as well, and then take a call for either mitral valve or suitable then double valve replacement.
Okay. So what is your conduct of the operation? What are all the precautions and this thing that you will do on table in
Um,
this patient?
Yes, if T shows moderate AR and it needs to be addressed, because class 2A indication concomitantly can be done with mitral valve. In case of mitral stenosis with moderate AR, then would go ahead with double valve replacement. In case of double valve replacement, uh, the cannulation strategy, aortic cannulation with bicaval venous cannulation. Uh,
That is there for mitral also. You will put
yes,
a single.
then
So what is there? There's no difference in that. That
and
doesn't.
uh, yes, uh, cardioplegia, cardioplegia, antigrade cardioplegia would be will suffice. With um cooling can be done once the root cardioplegia is given, in order to avoid aortic LV distension because of the moderate AR. Uh, Cooling up to 32 degrees. Cardioplegia, del nido, if it is del nido cardioplegia, can be used 30 ml per kg body weight, and with an interval of can be given total, can be used for uninterrupted 90 minutes. However, here it is repeated to be on a safer side after 70 to 80 minutes. If St. Thomas is used, then you can give it as 20 ml per kg with repeating at intervals of 20 to 30 minutes. Um, Once uh, uh,
No,
aorta
my
was trans.
yeah, that's all right. But my question was, what are the precautions? So the minute you open the chest, you must not
not
handle the
not
heart
maneuver it too much. Yes.
because this patient has a clot and he
Yes.
has had a previous embolization already. So that
Yes.
should have been your first answer. Then all your cannulation and then bypass techniques and myocardial protection and all comes later. So
Yes.
minimal handling of the heart until you have cross clamp the aorta so that to prevent embolization is a very important thing for you as a surgeon.
Yes.
Mm. So you must understand the question why the examiner is asking you using with relevance to this case. All right, because I
Yes.
said what you will do in this case. So that you must always keep the all the aspects of the case in your mind when you are talking. Okay, the examiner will ask you certain questions with certain things in his mind, so you have to answer those, because see, ultimately you have to make the surgery safe for the patient and patient safe for the surgery. That is the primary dictum of any surgical procedure.
Okay.
Yeah. Okay. So you think your root cardioplegia will work in this patient?
Initially, give root cardioplegia and then transverse aortotomy, and then continue after some time with LA venting with a stab incision, and then continue through till cardioplegia for total myocardial protection with the completion of the total dose of the cardioplegia.
No, no, I'm a little confused.
Moderate AF used
Why do you
for
need to
the,
do aortotomy for a root cardioplegia?
you can't give root cardioplegia.
Why
In
do you, what you're trying to say is, are you going to cannulate the individual coronary orifices and give direct coronary cardioplegia? Because root cardioplegia is just a needle in the ascending aorta.
Yes, first you can give it, and then in case of an moderate to severe AR, LV would distend, so LA is opened and then it is
How do
vented.
you know that the cardioplegia is going at all? If you put a root cardioplegia needle and give it, how do you know that it is going at all? It may be going into the somewhere else. This is
If
simple day-to-day practical question. Day-to-day, if you have done, if you have assisted some five cases, you will know. Forget more than that.
the pressure at the aortic root itself when we
Correct.
palpate with,
You should do that.
yes.
You should say that first. I will look for the distension of the aortic root and whether it is tense. So then I know that there is not significant AR and the cardioplegia will go through the coronary orifices. If it is not there, then sometimes you can just pinch the aortic root and see whether it will improve. If it doesn't happen there also, then you have to do open the aorta and give the cardioplegia directly into the coronary orifices. So that should be your answer. Will you give retrograde cardioplegia?
uh, it can be given, sir. It is helpful in a double valve replacement where you can give uninterrupted cardioplegia when you're using Saint Thomas, or even in
That
case of,
for retrograde cardioplegia, you have to manipulate the heart quite a bit. You already
yes.
have a clot in the LA in this patient, and you say that you're going to use del nido cardioplegia. So it gives you a
Only,
lot of time. So
yes.
preferably you should say that preferably because I'm using del nido cardioplegia, and there's a clot in the LA. I don't like to manipulate it, so I will avoid retrograde cardioplegia in this case. Although it may be useful because if you are going to do a double valve, but unless you open the this thing after cross clamping, you want to put an additional thing, you can do that later on. But before cross clamping, you should not manipulate the heart.
Right.
To put a retrograde cardioplegia, you have to manipulate it quite a bit, isn't it?
Yes.
So that should be your answer. See, these are all only pure common sense, practical questions.
Right.
So you must understand the question.
Okay.
Hmm. What temperature are you going to go down?
Uh, 32 degrees Celsius would be enough. But if it is taking longer, some surgeons even go up to 28 degrees Celsius. But in our OT, even for a double valve replacement, 32 degrees Celsius myocardial protection with topical cooling is adequate.
Okay. What else? You didn't put a vent line in this patient?
LA through LA was stabbed for
Good.
venting through the cardiotomy sucker
That
itself.
was a trick question, and you good. You because you are opening the LA anyway, so you don't need
Yes.
a vent. Okay. What are the pros and cons of topical cooling? What do you mean by topical cooling? What do you do?
Cold saline we put, sir. We don't use any ice slush or anything. Only cold saline is used.
Old saline will get warmed up in the theater lights. That's not going to be of much use. Sometimes people have used pads, cooling pads underneath in the posterior side, posterior behind the heart. But what are the dangers of these things?
Um, Proximity to the phrenic nerve can cause.
Not proximity, it because it will be a cold thermal injury to the phrenic nerves.
Yes,
Yeah. So you can end up with a phrenic palsy.
yes.
Hmm. So that is why many people don't want to use it. They will probably do systemic cooling to 28 and then come up. Okay. What valve will you use in this patient?
47-year-old mechanical prosthetic valve. Here we're commonly using now carbomedics or bicarbon bileaflet mechanical prosthetic valve, both in mitral and aortic position.
What are the two major arguments for using a biomechanical valve in this patient?
Already presence of thromboembolic episode with neurological deficit.
She's in AF, she requires anticoagulation
Mhm.
anyway. So you will use a mechanical valve. Another major thing, she has finished her family. She's got 3 children,
Yes,
living
sir.
children.
Yes,
So there is no more pregnancy going to happen, right?
completed family. Yes, sir.
And she is less than 50 years old. So a mechanical valve would be ideal for this patient.
Yes.
Right? Because any case you're going to keep her on anticoagulation. So carbomedics, you know all the details about carbomedics.
Yes, sir.
What is the opening angle of carbomedics? What is the inherent regurgitation fraction? And what is the
Opening angle in case of carbomedic
thromboembolic?
78 degrees, sir. In case of bicarbon, it is 70 degree. Both are tungsten alloys with pyroritic thin film coating of pyroritic carbon. There is no pivots or any struts like in St. Jude's. And bicarbon, the varieties come in aortic and mitral with slimline and flit-line. Slimline is in aortic position is useful in case of supraannular position. Supra and intraannular position with supraannular sewing ring and housing in the intraannular, and fit line in mitral position for severe mitral annular calcification or in a redo where it is irregular. So the fit line fits into the intraannular position snugly, and uh, carbomedics, you have top hat and for the supraannular position for a small aortic annulus, and carbomedics optiform is in mitral position for uh, redo or severely calcified or irregular mitral annulus.
Okay, I don't know much about these newer valves, but anyway, this is a good seminar topic for you people. The next batch that is coming up, you should present all the newly available valves and their pros and cons. So please, one of you must do a seminar on this, the later newly available valves, mechanical valves, so that we all know also. Okay, somebody
Yes.
can take do that. Yeah, not you. Your exam going anyway. After that, uh, after you pass, you don't need to read anything more, so it's okay. The next batch. Who is the next batch? The
The
present.
Soumya and Karan's match. That one is Hitesh, Roshan, Soumya. Karam, that
Yeah.
batch.
So they have to restart after you finish your clinical exam, we restart our seminars. So one of them should do this. Okay. All right. So you will do a mechanical mitral valve, this thing plus minus aortic valve.
Yes.
We have asked all the regular questions already. I don't have any new questions. What about anything new, sir?
The only thing is, when you palpate the apex, when you say it's in sixth space, you should have put your antenna up. This cannot be pure mitral stenosis.
Yes.
You
I
have
went back and I checked for aortic valve as well. So, but with AF and this loud S2, that early diastolic murmur, even in the forward position, I couldn't be appreciated. Sir.
that they will excuse you, but there must be moderate aortic regurgitation. There should be. Uh,
Yes.
uh,
Murmur, systolic murmur easily could be picked up, sir. But here she was a lean lady, no systolic murmurs. Sir.
it's a lean lady. It's easier to pick up the aortic diastole.
Yes.
What are the causes of mitral stenosis?
Rheumatic heart disease. Most commonly, the rheumatic heart disease congenitally can have congenital mitral valve lesions with supramitral ring, uh, or parachute mitral valve with a single papillary muscle. Then functional mitral stenosis can be there in other congenital heart disease with volume overload status like VSD, PDA, or as a part of left heart obstructulations, like for Shone's complex, there could be coarctation, subaortic obstruction, mitral with subvalvular obstruction with coarctation.
What other conditions mimic mitral stenosis?
Um, Left atrial myxoma or a thrombus or a vegetation causing mitral inflow obstruction can all mimic mitral stenosis.
Anything else? It's a
Uh,
rare thing. Not many people. I mean, it's not commonly seen, but it mimics mitral stenosis quite a bit.
in
Or
obstructive cardiomyopathy, also the obstructive
or
force,
striatum.
yeah, cord right. Yes.
Usually, the answer should be not don't bring congenital before that. That's it. First thing is most common in our country is post-rheumatic. Rheumatic heart disease producing mitral valve problems. And rheumatic heart disease usually affects the mitral valve in 70% and 20% mitral.
Mitral with aortic.
Pure aortic stenosis is much less.
Yes.
And the other thing is that when you take a history, only 50% of
The
the
rheumatic
gene
fever is
history of
yes.
rheumatic. But the other thing, when you enumerate the cause of mitral stenosis, one, rheumatic, and then what's the age group of presentation of rheumatic mitral valve disease?
Age group of mitral valve presentation, sir.
Yeah,
Uh, it can be affected, and most commonly in India, the natural history is 6 to 10 years, and then clinical signs can be appreciated 20. But usually in 30s is when they become symptomatic, with progressing to NYHA class 4 in untreated in the fourth decade. Uh, and with survival in untreated patients, it will be about 50 to 60% only. 5
don't
years
go and
survival.
analyze whatever you know. You
Instead of all that history, you should have just said second or third decade.
Yes.
See,
Simple.
normally, all textbooks say rheumatic fever is most common in the school going age between 5 and 15. That's a classical teaching of
Yes.
incident of rheumatic fever. In Western countries, they say the progression of rheumatic heart disease is so slow. It takes about 30 years. So the presentation of a rheumatic heart disease in the Western countries is between 40 and 50 years, 30 plus 50. So that's it. In India and Asian countries, there is an accelerated progression of the process in these countries. So, the youngest patient, I asked this many times, describe from India, the youngest patient,
3 years.
uh,
No, 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 no. Youngest patient who was operated
Oh,
in Vellore.
Padmavati,
Jairaj sir has told this some 100 times.
6 years is the youngest. Juvenile mitral stenosis, Stanley John used to say 6 years. And Padmavati has described the youngest rheumatic
yes.
mitral problem at 3 years. And I
Yes.
found recently some article from North India where balloon mitral valvotomy has been done in a child 1 year, 9 months, and I can't believe it. So this is so there's an accelerated progress of that's why in India they present and that never say if a patient with a more than trivial or moderate mitral regurgitation, never try to give the cardioplegia to the root. It's never accepted actually. And also about the retrograde, usually they give antigrade. That's enough because there is no coronary artery disease. So and you give retrograde, then you say you can continuously give it without interrupting your operation. But it's always better because when you retract the LA very much, the distribution of the corona, the cardioplegia in all the corners is not equal. So if there's no coronary artery disease, it's okay if you give, especially if the heart is not very sick. Otherwise, you have to give. And the retrograde is given the full heart, before you cardioplegia and you arrest the heart. Because you give the retrograde, put the retrograde cannula, the atrium is full.
Sorry, sir.
The retrograde cannula is put before cardioplegia, before arresting the heart. Okay?
Yes, sir.
And with guided through the coronary segment. And then the pros and cons of what happens. The right ventricle may not be protected as much with a retrograde cardioplegia.
Yes.
Anybody else has any more questions, doubts to clear before the exam?
If you, I don't know whether any of you follow Tendulkar's book, there must be 5 other causes of myxostenosis. He says SLE, Whipple's disease, Fabry's disease, mucopolysaccharidosis, all these things. You just go through that once. There are very rare causes, but can cause. But the most important thing is rheumatic, 2, elderly, mitral valve degeneration, calcification. Number 3, non-rheumatic mitral annular calcification. There's a process like that,
Yes.
severe annular calcification. And in that case, what can you do? What is Dr. P.V. Rao described in such cases? With calcium is so much in the annulus, you cannot remove the calcium because the coronary arteries may be in danger, or even perforation of the heart maybe. And it's mainly annular calcification. The valve orifice is not very narrow. In such cases, what can you do?
If decalcification is not very visible, then pericardium can be put over the annulus, and if mitral stenosis is also there, then um, a top hat or a supraannular level mitral valve processes can be inserted.
If the valve stenosis is not significant, I have described two techniques. One is positioning the valve in the atrium above the annulus.
Yes.
Okay. Number two, what Venkat has described is a chimney valve. Have you heard of that? I think
Yes,
it's
sir.
published that one.
Yes.
That means you stitch
Cylindrical graft is.
graft.
Yes.
You want to put a 21 valve, you put a 23 graft around the annulus, beyond the area of calcification, and put the valve in that. That's what. That's in cases of the non-rheumatic severe calcification of the annulus. Is a entity. Okay. You should know what is done in Narayana area. Okay. Any other questions? And as Krishna said, if you are planning to do a balloon valvotomy, absolutely a T is recommended because it cannot 100% rule out a clot in the left atrial appendage by a transthoracic echo. And there are two things, sometimes the embolus occurs, the whole clot disappears. That's one thing. Otherwise, the clot is there, which becomes organized and fixed to the left atrial appendage. In those cases, you do anticoagulant because no further fresh clot form on the organized clot. That's why all these patients are put on and minimal manipulation before you cross clamp the aorta and give cardioplegia.
Okay. No more questions. We'll close. Thank you, sir.
Thank you very much. Thank you.
Thank you,
Thanks,
sir.
thanks, Amulya.
Thank you, sir.